Good afternoon, dear students. Next lecture in gastroenterology. Today we'll talk about disorders of stomach and duodenum. But before we start our lecture, let me say a few words about general questions of what's happening now. You know that some of you are still at home, and we do our best to let you come back. That's why all students who are out of Russia should write applications to get new visa, as I know most of you own expired visas. That's why, please, if you have expired visa, you should write application to get new visa, to get invitation, make a copy of your passport, copy of your visa, old visa, and send this to contract department. Send all this to contract department. And I don't know why, but we'll inform you when invitations will be ready. After that, you can come to Russia. You know, even if you don't have direct flights from your country to Russia, you can use some Turkey, Emirates, and finally get Russia. Because medical education, it's impossible to have online education in medicine. And I'm afraid that medical councils of your countries may say that online education is not valid. That's why, again, write applications, we'll send invitation when it will be possible, and then you can come back and continue your studies in offline mode. Okay, this is general questions. Now let's continue our talks about gastrointestinal system, and today we start talking about stomach and duodenum. We'll talk about stomach and duodenum. So, stomach, which varies considerably in size, is divided into small area immediately distal to the esophagus, so-called cardia, the upper region, fundus. You know, a fundus of stomach placed on the top. We believe that fundus is something on the bottom, but fundus of stomach placed on the top of the stomach. Fundus lies under the left diaphragm, the mid region called as body of stomach, and the antrum, which extends into the pyloric region. Now, this is what you should know from anatomy. Two sphincters in the stomach, gastroesophageal sphincter and pyloric sphincter. The latter is largely made up of a thickening of the circular muscle layer, and the muscle wall of the stomach had three layers. The outer, so-called longitudinal, the inner, circular, and enormous oblique layers of smooth muscles. So three layers of smooth muscles. Actually, that's why stomach is a very strong organ with very good muscle system. Duodenum has outer longitudinal and inner smooth muscle layers. It's C-shaped, and the pancreas lies in the concavity. So C-shaped, meaning that caput of pancreas placed in this C character. It terminates in the jejunum and the duodenojejunal flesh. The upper two-thirds of stomach contains parietal cells, which secrete hydrochloric acid, and chief cells, which secrete pepsinogen, which initiates proteolysis. The antrum contains mucose-secreting and G cells, which secrete gastrin. Mucose-secreting cells are present throughout the stomach and secrete mucose and bicarbonate, which is trapped in the mucose gel. The mucose is made of glycoproteins called mucins. Somatostatin, the local hormone, is also produced by specialized antral cells, so-called D cells. Stomach, it's a rather unique organ, because what for we need stomach? To digest mostly proteins, because pepsin enzyme, which produced as a pepsinogen by stomach, This is very powerful enzyme which can digest proteins. But stomach itself made of proteins. That's why how it's possible to digest something, but to avoid self-digestion. For this, we have special protecting systems. We have mucosal barrier made up of the surface membranes of mucosal cells, and the mucose protects the gastric epithelium from damage by alcohol, aspirin, non-steroidal anti-inflammatory drugs, bile salts, and mostly from pepsin. The duodenal mucosa contains so-called Brunner's glands, which secrete alkaline mucose. What for we need alkaline mucose? Because again, in stomach we have high acidity, a lot of acid. But when food with this acid reach duodenum, acid should be neutralized. And for this we have alkaline mucose. This, along with the pancreatic and biliary secretions, help to neutralize the acid secretion from the stomach when it reached the duodenum. Function: the secretion is under neural and hormonal control. Both stimulate acid secretion through the direct release of histamine on parietal cell. Acetylcholine and gastrin also release histamine via the enterochromaffin cells. Somatostatin inhibits both histamine and gastrin release and therefore acid secretion. So now just remember that hormone which increases gastric secretion, this is histamine. Histamine, this is local hormone which increases gastric secretion. Somatostatin, vice versa, inhibits histamine and gastrin release and therefore acid secretion. Histamine increase, somatostatin decrease gastric secretion. Now this is chart showing what I told you. We talk about anatomy of stomach. We talk about this part is known as cardiac part. This is fundus. Fundus. This is body. Then we have antral part, antrum, and pyloric channel. So, other major gastric functions. Acting as a reservoir for food. No, it's clear that we eat a few times per day, but then our digestive system should digest all this stuff the whole 24 hours. And actually, stomach serves as a reservoir for food. Emulsification of fat and mixing of gastric contents. You know, food we eat, yes, first we use our teeth to destroy food, but then, you know, that stomach has a lot of muscles, I try to explain. And when these muscles contract, it leads to emulsification, mixing of gastric content. Mixed in with what? Mixed in with enzymes, mixed in with acid, because enzymes and acid should reach each molecule of proteins, for example. And to do this, it should be good emulsified and good mixed. Secretion of intrinsic factor. You know that parietal cells can produce so-called intrinsic factor, or it's known as castor factor. This protein, which do very important thing, it protects B12 vitamin from destruction. Because B12 vitamin we get from meat, animal products, but this vitamin B12 should pass all small intestine, and it's absorbed only in the terminal part of small intestine. Without protection, this B12 vitamin may be destroyed, and even we eat normal amount of B12 vitamin, it can't reach the place of absorption, and the result will experience B12 deficiency. And you know that B12 deficiency is very bad because it leads to very serious problem known as B12 deficiency anemia. Or in the past, it was known as pernicious anemia, underlying the persons with such disease die soon. Yeah? It's potential lethal disease. And actually, if someone suffered from serious stomach problems or even removing of stomach, for example, after some surgery on cancer, don't forget that this person should get enough B12 vitamin in injections, not in tablets. Because again, without intrinsic factor, without such kind of protection, B12 vitamin can't reach place of absorption, and as a result, patient will experience deficiency of vitamin B12. What else stomach do? Absorption. Absorption. No, minimal importance, because actually main function of gastric of the stomach is digestion. Absorption in very small amounts. Don't forget about other very important feature or function of stomach. This is protection function. Protection. Because stomach, the place where we have high acidity, very active enzymes, stomach can destroy most of germs. And that's why it's some kind of protection. It's some kind of protection. You know, it's interesting. Please think about that in most of South countries like India, people prefer spicy food. I know that you like spicy food a lot. And you know that in Russia, yes, we have something spicy, but not as spicy as in India. Why so? No, you may say this spicy is tasty. Yes, spicy is tasty. But you can also find the same in some African countries. Why spices? What spices do actually? They stimulate secretion of gastric juice. All kinds of spices irritate stomach and increase production, stimulate production of gastric juice. And gastric juice is a good protection because it can destroy easily actually all pathological germs, for example. Yeah? And when we are traveling abroad, when, for example, when I'm going to travel to India, one of advice is eat a little bit all the time. Don't have your stomach empty, because empty stomach has low acidity, low acidity. Or use so-called aperitifs. Aperitifs, it may be just juice, or actually, if you wish, small amount of alcohol. Why? Because all this stimulates secretion of gastric juice. And again, it protects us against different germs, protects against different germs. Okay, gastric emptying. Gastric emptying depends on many factors. By the way, after meals, usually food stay in the stomach about 1.5 to 2 hours, depending on how heavy is food. For example, fatty food stay in stomach longer. That's why after fatty food, you feel some heaviness in the stomach for a long time. So what about gastric emptying? There are so-called osmoreceptors in the duodenal mucosa that control gastric emptying by local reflex and the release of gut hormones. So now we know physiology of the stomach, and now let's start talking about disorders. Let's start talking about disorders. First disease we'll talk about, this is gastritis. This is gastritis or inflammation of stomach. You know, itis means inflammation. Cholecystitis, pancreatitis, gastritis, ending itis meaning inflammation, So gastritis is defined as inflammation of the gastric mucosa regardless of its etiology. Right? So inflammation of gastric mucosa regardless of its etiology. We have a classification of gastritis. The commonest cause of gastritis is Helicobacter pylori infection. About 80% of all gastritis, this is due to Helicobacter pylori infection. And such kinds of gastritis, known as gastritis type B. Why B? Bacterial. The gastritis type B. This is gastritis caused by bacteria, and not all bacteria, but specifically Helicobacter pylori infection, Helicobacter pylori infection. Gastritis type A, character A. This is autoimmune gastritis, seen in 5%, while the remaining causes includes viruses like cytomegalovirus, some herpes simplex, disorders of duodenogastric reflux, and specific causes. So again, if we talk about gastritis, number one place, this is gastritis type B. I mean actually chronic gastritis, of course. We are talking about chronic gastritis. The chronic gastritis B, this is bacterial Helicobacter pylori, and chronic gastritis A, autoimmune gastritis. No, and of course we have some exceptions, rare causes like other viruses and so on. Next, very important idea. Term gastritis should be reserved for histologically documented inflammation of the gastric mucosa. What we are talking about, that very often when patients presented with some dyspeptic symptoms, like some heaviness in epigastrium, sometimes pain in epigastrium, sometimes feeling of full stomach, all kinds of dyspepsia. In the past, doctors diagnose gastritis. You know, you have chronic gastritis, don't worry. Now, it's not enough to say that someone suffers from gastritis. You should have histological proof of gastritis. So, what does it mean histologically proved or histologically documented? It means that you should perform fibrogastroscopy, you know, such as fibrogastroduodenoscopy. Right? So, esophagogastroduodenoscopy. This is special fiber optics, that device, which can be inserted into stomach. We can first of all observe. This is good optics. You can see actually all ulcers or some damages of mucosa. But next, what you should do? You should do biopsy. Biopsy, this is when we take piece of tissues. This is special small device which can bite a piece of gastric mucosa. By the way, it's absolutely painless because I told you in gastric mucosa, we don't have pain receptors. That's why, again, doctor make a small bite. No, you may say it's bleeding, no, bleeding, and then if you have small wound, it's disappeared. The same happens in the stomach. We get this piece of actually tissues, and we should take these biopsies at least in several parts of the stomach, in body of stomach, in antral part of the stomach. Then you will send all this material to histologist, and using microscopy, histologist should find signs of inflammation. You know signs of inflammation. This is accumulation of immune cells, neutrophils, eosinophils. So, and if you see this, you see damage of tissues, you see signs of atrophy of parietal cells, plus presence of actually neutrophils or eosinophils. If you see all this, you can see, okay, histologically, this is gastritis. And only in this case, you can write in case history, gastritis. Why it's so strict now? Because correlation between the histologic findings of gastritis and clinical picture of abdominal pain or dyspepsia and endoscopic findings noted on gross inspection of the gastric mucosa is very, very poor. So what does it mean? Patient may have a lot of complaints, pain, dyspepsia, some bad feeling in the stomach. We perform fibroscopy, we perform biopsy and find nothing. Absolutely normal stomach. In this case, we can't say that this is gastritis. And vice versa. For any reason, we take sample of gastric mucosa, we see gastritis, but patient has no clinical presentation, no signs, no complaints, nothing. That's why no correlations between severity of histological inflammatory process, and clinical presentation, patient's complaints. That's why to say that this is real gastritis, you should do biopsy, histological investigation. But what to do if patient presented with complaints, but his stomach is normal? Does it mean that patient just lied? Not of course. Patient really feel something wrong. But in this case, we talk about functional disorders. We talk about we use term non-ulcer dyspepsia. Patients suffer from non-ulcer dyspepsia. Dyspepsia, it's clear, this is presentation of some complaints. Non-ulcer, no ulcer, no other histological findings in the stomach. And most of people who presented with such complaints, this is really patients with non-ulcer dyspepsia. Non-ulcer dyspepsia, this is functional disease. Functional disease, when disease not accompanied with damage of morphology, some structures, patient feels something, but we can't find reason, no visible signs. No, it's possible to explain, it's a separate story. We tell about hypersensitivity of stomach wall. We talk about some neurological problems, so nerve central information. But what you should remember, that gastritis, this is morphological diagnosis. If you didn't perform fibroscopy, you can't say that someone suffer from gastritis, Now again, I told you already that we have following classification of gastritis. We have acute gastritis and we have chronic gastritis. Acute gastritis, number one place, this is acute Helicobacter pylori infection, and other infections like bacterial other than H. pylori. It may be mycobacterial, it may be syphilitic, viral, parasitic, fungal. So all bacteria finally can cause inflammation of stomach, but it's happened very rare because again, stomach has so strong digestive properties that if bacteria somehow manage to invade, they just destroyed by actually gastric juice, more interesting for us, this is chronic gastritis. And again, among chronic gastritis, we have chronic gastritis type A. So autoimmune gastritis also, it's known as body predominant. Why body predominant? Because this gastritis mostly affects body of the stomach. Why? Because body of the stomach contains parietal cells, and parietal cells affected by this disease. Type B, this is pylori related, because usually this inflammation happens in pyloric part and caused by Helicobacter pylori. It's caused by Helicobacter pylori. No, we also tell it's antral predominant, not antral, the antrum of the stomach. Antral predominant caused by Helicobacter pylori. No, and C, indeterminate. We have inflammation, but we can't understand why it's happened. No Helicobacter pylori, no autoimmune disease, but still we have some inflammation. It's also possible. And in this case, we talk about indeterminate. Now, of course, we have some uncommon forms of gastritis like lymphocytic, eosinophilic, Crohn's disease, sarcoidosis. No, actually, we have rather rare disorders which can also affect stomach, causing inflammatory process. Now, in this case, we talk about, for example, gastritis of Crohn's disease. Now, in this case, it will be Crohn's disease. Between Crohn's disease may affect all parts of gastric tube from, as we say, from mouth to anus. No, this is rare forms of gastritis. Remember, please, two main, type A, type B. Again, type B, almost 90%, and only 5%, this is type A. Almost all gastritis we have, this is gastritis caused by Helicobacter pylori infection. Okay, Helicobacter pylori is a gram-negative organism with many attributes that allow it to have a unique ecological niche in the human stomach. So I told you already that stomach can kill all bacteria. And it means that Helicobacter pylori somehow managed to survive manage to survive in the stomach, survive in acid? How it's possible? So inflammation induced by Helicobacter pylori is usually superficial, preferably located in the foveolar or gastric pit region and upper portion of the lamina propria, and consists of mononuclear cells and polymorphonuclear leukocytes. So what we're talking about, again, how we can see under microscope that this is inflammation. This is accumulation of some immune cells. And mostly this is accumulation of mononuclear cells and polymorphonuclear leukocytes. The polymorphonuclear leukocytes. Helicobacter pylori infection is causally associated with gastritis, duodenal and gastric ulcer, and gastric adenocarcinoma. So it meaning that presence of Helicobacter pylori in patient's stomach lead first to gastritis, then to gastric ulcer, and then to gastric adenocarcinoma. When we'll talk later about peptic ulcer disease, you will know that #1 cause of peptic ulcer disease, this is Helicobacter pylori infection. Helicobacter pylori infection. And Helicobacter pylori infection cause so-called cascade, one by one, step by step, damage of the stomach. First, gastritis, then ulcer, then cancer. Infected subjects have about a 1 in 6 lifetime risk of peptic ulcer. Lifetime risk of gastric cancer varies from 1 to 3% in the United States and more than 12% in Japan. What does it mean? That not all people with actually Helicobacter pylori infection produce peptic ulcer or produce cancer. So again, if someone carries Helicobacter pylori, only 1 out of 6 produce peptic ulcer, and only 1 out of 100 or 3 out of 100, what means 1%, 3%, 1 per 100 that produce cancer. No, for example, in Japan population, it's much more worse, and presence of Helicobacter pylori lead to stomach cancer in 12% of cases. In 12% of cases. That's why in some people, Helicobacter just live and bring no real harm. Bring no real harm. But to say the truth, if Helicobacter stay for a long time in the stomach, it produces inflammation, it produces gastritis, but it does mean that it produces ulcer or cancer, ulcer or cancer. So, no, this is photos. You see these small bacteria. This is Helicobacter pylori, Helicobacter pylori. No, this is electronic scan microscopy showing us these bacteria. By the way, it's interesting. Why they are called Helicobacter? You know, in the past also we used Campylobacter, but now we use term Helicobacter. Why Helicobacter? What is it, helicobacter? You know, it's from the word helicopter. Helicopter. Why helicopter? What's the same between helicopter and bacteria? You know that these bacteria at the end, they have a tail. And this tail can make round movements with very high velocity, round movements. And it looks like as a small helicopter. It looks like as a small helicopter. That's why it's called Helicobacter. Helicobacter. Now another picture of, again, when we see a lot of, you see these small bacteria, this is Helicobacter infection. Helicobacter infection. So, Helicobacter pylori causes a chronic serious infection. Humans are the only known reservoir, so this is human infection. We can't find such infection in pets, in cows, or in other animals. So transmission is opportunistic in that many method that allows the organism access to the stomach is likely to be a mode of transmission. Now, the most common modes of transmission involves lapses in household hygiene or ingestion of contaminated food or water. Waterborne infection has been documented. Infection may result from exposure of gastric juice of infected individuals, including contaminated nasogastric tubes, endoscopes, but to say generally, this is oral fecal infection. So bacteria can be excreted with feces, and if in case of poor hygiene, contaminated water, bad hygiene of hands, it may be transmitted from one person to another person, from one person to another person. Again, poor hygiene, poor hygiene. Infection typically is acquired in childhood. Why in childhood? Because children, they have not so strong stomach. The acidity of stomach is not so high. That's why usually infection acquired in childhood. Adults tend to become infected when children are in the family. Epidemiology of Helicobacter pylori reflects a pattern typical of person-to-person transmission with high prevalence at a young age in developing countries and impoverished subpopulation of poor people, other words, the poor people in developed countries. Because the rate of accusation has been decreasing in developed countries, old individuals have a higher prevalence than young individuals, reflecting their high rates of accusation at young age. So what we're talking about? In the past, it was investigation that almost all elder people suffer from this infection. Up to 80%, 90% of people were infected. Now, as hygiene becomes better, life quality becomes better, people live better. Now, children and young adults infected not so commonly. It's not so common case of infection of young people and children if you follow all hygiene prescriptions. That's why, again, more infection in poor countries, less infection in rich countries or developed countries. More infection in elder people, less infection in young people. Less infection in young people. This decrease also possibly is related to the increasingly high levels of hygiene, which limit transmission, and the widespread use of antibiotics for other infections, which may cure a portion of the existing H. pylori infections. So what we're talking about? Why now we have less H. pylori infection? Because we widely use antibiotics. And if you prescribe antibiotics to treat pneumonia, for antibiotics, never mind what to kill, which bacteria, in lungs or in stomach. And that's why sometimes when we prescribe antibiotics to kill germs in the lungs, we at the same time kill germs in stomach. And that's why it will be curance without actually purpose. In developed countries, the decrease in prevalence of H. pylori infection parallels the decrease in the incidence of peptic ulcer and non-cardiac gastric adenocarcinoma. This is very serious conclusion. Meaning what? Less number of H. pylori infection, less number of patients with cancer and with peptic ulcer. It's also big proof, good proof, that cancer and ulcer caused by H. pylori infections. Again, less contamination, less prevalence, less number of peptic ulcers, and it's great. So, diagnosis of Helicobacter pylori infection. How to diagnose, how to detect. We have two types of methods, non-invasive and invasive. Non-invasive and invasive means that we should cut something, bite something, take some material. Non-invasive, it means we shouldn't do this. No, the best method we know, this is so-called C13 urea breath test. C13 urea breath test. This is quick and easy way of detecting the presence of H. pylori, and it's used in a screening test. So, measurement of C13 CO2 in the breath after ingestion of C13 urea requires a mass spectrometer, which is expensive, but the test is very sensitive, about 98%, and specific, 95%. The breath test is also used to demonstrate eradication of the organism following treatment. So what we're talking about, idea of the test is simple. You know about isotopes, the isotopes. This is atoms with different weight. Why they have different weight? Because they have different number of neutrons, and all elements, they have isotopes. And isotope, specific isotope for carbon, for C, this is C13. You know, bacteria, Helicobacter pylori, how it's managed to survive in acid? Because bacteria can neutralize acid. How neutralize acid? Bacteria can destroy urea, which present in blood, and release carbon dioxide and ammonia. Ammonia neutralize acid. Yeah? And that's why what we do, we give patient to drink some small amount of urea, which contains specific C13 isotope, which is never present in our daily food, and that's why it can't be produced normally in our body. If bacteria present in the stomach, that if patient carry this bacteria in his stomach, what happened? This bacteria destroy urea and release CO2 with C13. Patient breathe, and idea of the test very simple. First patient drink, and then after a few time, after half an hour, breathe into special tube. But this tube connected to mass spectrometer. Mass spectrometer, this is device which help us to detect these isotopes. It's very expensive. It may cost up to $1 million, 1 million USD. That's why this is rather expensive test, very expensive test, but very good. Nothing, no blood, nothing, just breathe and so you will get result. Serological tests. Now, you know serology. This is when we examine blood. We examine blood, what for? We are searching for antibodies against something. Serologic test for COVID-19, we search for antibodies, you know, immunoglobulin G, immunoglobulin M against COVID-19 infection. Everybody knows about this. But we can do the same, searching for antibodies against H. pylori. If H. pylori present in patient's body, immune system react, produce antibodies, and these antibodies can be detected. Immunoglobulin G titers may take up to 1 year to fall by 50% after eradication therapy. So what we are talking about? Now, this test is good for screening, for investigation of big populations. But for example, you have patients, you detect H. pylori, you prescribe antibiotics, and you should know, you kill it or not. Serological test can't help because antibodies may stay in patient's blood for many years. That's why it's not so sensitive and good for detection of succeed of our treatment. Stool test. It's possible to detect antigens of H. pylori in feces. No, if this bacteria live in stomach, with food it then go to intestine, then to large bowel, and then evacuate it with feces. We can use PCR reaction, polymerase chain reaction. Everybody know about this because yes, we use PCR reaction to detect COVID-19 infection. But again, we can do this to detect H. pylori infection. That's why we can use such test, PCR polymerase chain reaction, to detect antigens of H. pylori in patient feces. No sensitivity, about 90%. Rather good sensitivity. Invasive methods. For invasive methods, we need endoscopy, fibrogastroduodenoscopy. We take sample of patient's mucosa. We get this sample and do what with this? Now we have so-called rapid urease test. Gastric biopsies are added to a rare solution containing phenol red. If H. pylori are present, urease enzyme splits the urea and release ammonia, which rise pH of the solution and cause rapid color change. No, actually, sometimes it's not solution, it's special paper, which actually has some chemicals. We just put piece of gastric tissue on this paper, And if around this piece we have change of color, okay, this is positive test. Cultures. No, we can grow. We can even try to grow H. pylori. No, it's rather long. No, it's need to detect, for example, sensitivity to different antibiotics of this bacteria. Histology. No, I showed you picture. Just make histological investigations and search for bacteria in patients' mucosa. But we have much, all these tests, rapid urea tests, cultures, histology may help if patient has a lot of bacteria in his stomach. But sometimes the amount of these bacteria are not so big, and that's why we can miss bacteria. To avoid this, we can use again PCR test, polymerase chain reaction test. But in this case, we take sample of patient mucosa and searching for patients for H. pylori antigens already in gastric mucosa. Now, this is very sensitive test because even very small amount of H. pylori, if it's presenting, it's easily detected by polymerase chain reaction, So these main methods for detecting of H. pylori infection. Now, again, this is some pictures. We see this is urea. Then urease produced by Helicobacter pylori lead to breakdown of urea to carbon dioxide and ammonia. And this carbon dioxide, patient breathe out and detected by this actually mass spectrometer device. So, few words about acute gastritis. The most common cause of acute gastritis are infections. Acute gastritis caused by infection H. pylori and acute infection with H. pylori induces gastritis. However, H. pylori acute gastritis has not been extensively studied because what is acute gastritis? Everybody experiences periodically acute gastritis. Sometimes we refer as food poisoning. Know what? After eating of something, what we have? Some epigastric pain, nausea, vomiting. No, usually it's all disappear in 1 or 2 days. And that's why we never do fibroscopy during acute gastritis. No, what for? If you do this, yes, you can find some infiltration of neutrophils with edema, hyperemia, in case of histology. If not treated, this picture will evolve into one of chronic gastritis. So, what's the problem? Okay, patient has something like food poisoning. After 1 or 2 days, everything disappeared. Everybody happy, but what happens? If it was H. pylori infection, this H. pylori infection may shift to chronic, and after acute gastritis, patient may start suffering from chronic gastritis. And remember, I told you that no clinical presentation, or very poor clinical presentation of chronic gastritis. And then patient lived with this chronic gastritis many years. Then he gets peptic ulcer and then stomach cancer. No, highly acidic gastric environment may be one reason why infection process of stomach are rare. Bacterial infections of stomach of Leishman's gastritis is a rare, potentially life-threatening disorder characterized by marked and diffuse acute inflammatory infiltrates of the entire gastric wall, at times accompanied by necrosis. Not only elderly individuals, alcoholics, patients with HIV infection may be affected because very poor immune response, Now, in chronic gastritis, defined histologically by an inflammatory cell infiltrate consisting primarily of lymphocytes, plasma cells, with very scant neutrophil involvement. Again, please remember, gastritis, this is histological diagnosis. To say that someone suffers from chronic gastritis, you should do fibroscopy, get sample, and detect inflammatory process. Distribution of the inflammation may be partially initially involving superficial and glandular portions of the gastric mucosa, And this picture may progress to more severe glandular destruction with atrophy and metaplasia. Again, chronic gastritis type A autoimmune, type B H. pylori related, and IB gastritis also possible. AB gastritis, this is due to mixture of bacterial and autoimmune gastritis. Few words about gastritis type A. You know, this is autoimmune. You know this idea of autoimmune disorders. We don't know why, but our immune system releases antibodies against our own tissues. Result, destruction, death of these tissues, and problems. In case of autoimmune gastritis, we have attack of parietal cells, the autoimmune antibodies attached to parietal cells, kill parietal cells. Clinically, we see what? Low acidity. So we have low acidity, no production of acid. But patients in many cases can't even feel this because, again, we eat cooked food. Cooked food, this is already half digested food. And that's why if patient even has no acid in his stomach, no, nothing terrible happened. Nothing terrible happened. We use cooked food, all bacteria is already killed by boiling or by frying. As a result, no clinical signs, no clinical signs. And you know that in many cases, autoimmune gastritis detected due to more advanced presentation of B12 deficiency anemia. We see patients with anemia and searching what happened, why patient has autoimmune deficiency anemia, what happened with B12 vitamin. We examine in patient and find autoimmune gastritis, So antibodies to parietal cells have been detected in more than 90% of patients with pernicious anemia, what I told you. No, parietal cells containing gastric gland, preferentially targeted in this form of gastritis. No, parietal cells, source of intrinsic factor. No, and again, I explained to you what happened in case of damage of these cells. No intrinsic factor, no B12 vitamin, as a result, B12 deficiency anemia. No, and gastritis type B, the antral predominant. By the way, why antral predominant? Because bacteria try to live in place of the stomach, where there's less acidity. You know that parietal cells placed in the body of the stomach, and that's why in the body of the stomach, very high acidity. That's why to escape, bacteria try to live in antral part of the stomach, where no so big amount of acid. Now again, caused by H. pylori, no increase with age, and you know, in patients over 70, in some cases they refer that almost all people, elder people, may suffer from gastritis type B, But what's good that if you eradicate H. pylori, you give treatment, usually antibiotics, and kill bacteria. No bacteria, no gastritis. Of course, we never have complete recovery, but at least we don't have progress of the disease. Let it be just gastritis, but we can avoid cancer, we can avoid ulcer. No, this is pictures again. You see these red spots. This is inflammation caused by Helicobacter pylori infection. The gastritis caused by Helicobacter pylori infection. Okay, that's all. What about gastritis? What about chronic gastritis? If you have some questions, you can type these questions, your questions in the chat. Please type questions in the chat. We have a few minutes for your questions, and I'll try to answer your questions. Do you have questions? Write or type in chat. No, if no questions, okay, you will have your classes and ask your teachers if something is not clear. Okay, for today is enough. Again, next lecture will be after 2 weeks. Today we have 15, it will be 29 of September. Next week, no lecture in investigation of therapeutic patients. These lectures will be delivered late. Okay, no questions. Good luck and bye.